I think the totality suggests that we have finally found a therapy that can alter the compartmentalized inflammation that is driving progressive MS.
But with these trials, it suggests that tolebrutinib showed a clear reduction in disability accumulation despite no differences in relapses versus teriflunomide. And these results are consistent with the hypothesis that acute focal inflammation and smoldering neuroinflammation are two distinct biological processes.
So the primary outcome, looking at confirmed progression, showed that there was no effect on simvastatin in reducing the progression rates.
So what we find is that there was a higher overall genetic burden for depression was associated with increased disease activity in people with MS. This is from 4 cohorts across 3 different countries.
I'm going to talk about a patient's journey with MS and how AI in different aspects can impact potentially in the future how we diagnose, look at the prognosis, monitor MS.
When we decide to de-escalate, extending infusion intervals can be a feasible way, somehow preserving the efficacy, at least on the inflammatory activity. But definitely more studies are needed to understand, first of all, the B-cell role in MS pathogenesis, because it's really a big question mark yet.
Direct from Copenhagen, in Denmark, you're listening to the ECTRIMS podcast, the official podcast channel of the European Committee for Treatment and Research in Multiple Sclerosis. I'm your host, Brett Drummond. Welcome to this special Congress series. The 40th anniversary of the ECTRIMS Congress has just concluded, and once again it was an incredible meeting. Participants from all over the globe have come together to share the most cutting-edge research into multiple sclerosis across the 4 key tracks: clinical, pathogenesis, imaging and non-imaging biomarkers, and therapy. It has been a celebration of the past and all of the progress made to this point, while maintaining a laser focus on the future and all of the work still to be done to ensure that we achieve the best outcomes for people living with MS and related conditions. In this episode, we bring you the key highlights of Day 3 of ECTRIMS 2024. Today, I'm joined by Alan Thompson, Professor of Clinical Neurology and Neurorehabilitation from the University College London in the UK, and also a host of the ECTRIMS podcast. Alan, thank you for joining me.
Pleasure.
So as a quick starting point, as I just said in the introduction, you're obviously a fantastic host of the ECTRIMS podcast. It's nice to finally connect with you on one of these episodes. You've done a number of excellent episodes yourself. How does it feel to be on the other side of the microphone today?
I think I'm slightly more comfortable being the host, to be honest. But at the same time, it's quite good fun to be at the other end.
Indeed. I'm really looking forward to this episode. It's great to be able to chat. So we have a lot to talk about. It's been a really big day of sessions. Late-breaking sessions have just happened, and there was a lot of interest in those. So I thought maybe we would start with them. And a couple of the clinical trial results presented were on tolebrutinib, a protein tyrosine kinase inhibitor. Do you want to share your thoughts on those results and the potential impacts of them? Maybe starting with the Gemini study.
Certainly, I think they underline the value of ECTRIMS as a meeting where you can have results of different trials presented one after the other, and then a live discussion in front of the audience as to what those results might mean. And of course, we've had a number of studies on the inhibitors. So this is one in a series. I think for the Gemini, which focused on relapsing MS, it was perhaps not a surprise. This was comparing it to teriflunomide. It was not a surprise to see that there was really no effect on the annualized relapse rate, no difference between the 2 arms. So that was the primary outcome of the study. So the study was, in effect, a negative study. As ever, some of the more interesting results are in the secondary outcomes. And while one has to be careful how you interpret them, because that's not what the trial was set up to look at specifically, nonetheless, they give you valuable hints as to disease mechanism or perhaps also the effect of the drug. So there we saw that there was a 29% reduction in disability progression, disability independent of relapses, what we've now come to call PIRA. So that's really interesting in this relapsing group. And raises hope that perhaps with appropriate targeting, this agent may have a role in the treatment of MS. And of course, against that, and because nothing is ever straightforward in MS, we actually saw more gadolinium-enhancing lesions in the treatment arm, which is not what you'd expect. And in addition, the enlarging lesions were similar in both arms. So there's a little bit of a discrepancy here between what we're seeing clinically and what we're seeing on imaging, which I think raises questions, as people always say, more questions than answers, which we need to go back to. But it was really helpful to see the results presented so clearly and to have some time now to think about what they might actually mean.
I think it's the importance of sitting in these sessions at the Congress to be able to see this, because when we obviously had some hints as to what the results from Gemini were going to be a week or two ago, and that focused on that primary outcome. But sitting in this, as you say, there's a lot more to unpack from this trial that we really need to sit down and think about, having seen what a lot of those secondary outcome measures look like.
It's true. I mean, we have to be careful. The primary outcome was clear, and that was negative. But then it's following up on some of these new insights to see where they might lead. And of course, it was particularly helpful to have the next study, the Hercules, presented immediately afterwards, and to be able to do it. And the speakers, and I saw this a lot stepping back from the meeting, cross-referenced each other a lot. And that, again, to me, is one of the great values of the meeting, that actually there's a lot of linking up at the meeting between the presentations, which is something perhaps we hadn't seen in the past.
Yeah, definitely. So I guess shifting then to talk about the Hercules study, looking in non-active SPMS. Do you want to talk us through your thoughts on those results?
Yeah, I mean, first of all, you use the term non-active, but so what we're really looking at is patients with secondary progressive MS that are not having relapses. But they are, of course, progressing, and some people would consider that to be activity. So these are people who have had no relapses for 2 years. And in fact, for most, it was 7 years since their last relapse. So they were a very quiescent, from a relapse point of view, population. But they did show 12 months of confirmed progression. And here, there was a very clear-cut outcome on the 6-month confirmed disability progression, with a 31% reduction in this was drug against placebo, so it was a placebo control rather than another active agent. So that's very exciting, because this is a population. So treating progression in MS, which we might come on to again when we talk about the statin trial, is one of the great challenges for us all. And to be able to demonstrate an effect on non-relapsing patients that are showing a progression is really exciting. And again, it raises issues about, well, what actually is the underlying mechanism for this clinical manifestation? And can we get at that? And then can that open up to other treatments? I mean, in terms of mechanisms, of course, the slight quandary here is that when you look at slowing of brain atrophy, which is what you might expect as the main biomarker of progression, there was no difference between the two arms. And that is really unusual and strange and needs a lot of thinking about. And again, it may be telling us that our rather simplistic interpretation of MRI biomarkers needs a bit of a rethink and maybe needs to be a little bit more sophisticated. And it may be that when we move on to more nuanced biomarkers, imaging biomarkers, we'll be able to dissect out some of these questions. So, a positive outcome, which is huge given the population and not to be underestimated at all. And then further to have a look at what does this actually mean and what are the mechanisms that we might be able to target with other agents.
Yeah, definitely. And I guess just one final point on both of those trials. One of the things that we knew while the trials were being undertaken was that there were some concerns around some of the liver side effects and adverse events that were being observed. They obviously presented some updates on those throughout the trials. Based on what you saw there, do you feel confident in terms of the use of this therapy moving forward, that that's not going to be a barrier to use? Difficult question to answer.
Yeah, it is. And I'll always caveat it by saying, of course, what you see in trials, as we know from many other studies, may not translate into the real world. So you may get hints within trials, but then when you actually treat patients, you realize that it could be either more or less problematic. But what I would say is that it's something that clearly needs to be monitored. And I think the next phase, sort of 4 studies, would be really important in getting a sense of how common these side effects are with the liver in particular, and just how serious they might be. So I'm sitting on the fence slightly.
So the other trial that you mentioned that we also saw during that late-breaking session was the trial results on MS STAT2. This is obviously a trial that's been ongoing for a number of years. We've been awaiting the results for. We didn't have any hints as to what the results were going to be from this one. Obviously, we've come through and seen, and possibly not the results that we were hoping for. But again, do you want to share your thoughts on those findings that were presented?
Yes, absolutely. I mean, Jeremy Chataway gave a very clear presentation, and not for the first time, he presented on an emphatically negative trial. So this was, I think, really disappointing. This has followed on from a phase 2 trial, which was, perhaps to our surprise, really positive, both in terms of the clinical outcome, the EDSS, and MRI. So that was sort of double. That gave us a lot of hope. It was a trial which required the most extraordinary organization, both in terms of funding, because of course this is not industry funded. So getting funding from the MS charities and from government was really difficult, but manageable. And I think looking at how well the trial was carried out, it was fantastically well done with amazing completion figures. And I guess just demonstrates that it is possible to do these trials. But it also demonstrates how difficult it is to show an effect on progression, in a way making the previous study all the more remarkable. But it does indicate that progression in MS remains really the most challenging aim we have, and we've got to keep focused on it. So when I think about the work of groups like the Progressive MS Alliance, how important it is that they carry on with their work. So in summary, this did not show an effect on disability. It was emphatically negative from the beginning throughout. It was consistent. And that is very disappointing for everybody. But it is beholden on us to move from here and do some further trials that are focusing on mechanisms of progression. I guess one of the things to say is that we were never really sure about the mechanism by which statins might have an impact on progression. And some people even thought it was just their impact on comorbidities, which is clearly not the case. But at the same time, it all comes back to us getting a better hold on, or a grip of, underlying mechanisms and then targeting those.
Yeah, I couldn't agree more. So obviously the late-breaking abstract session was massive, where there was a lot of anticipation around those clinical trial results. But while that was going on, there were also a number of other sessions today that focused on a number of other really important and exciting areas. I know you were keen to talk about a few of those that you also interacted with. What were some of the other sessions that caught your eye on other topics?
I was particularly interested in the AI and machine learning session, and not just because one of my postdocs was presenting and is doing a lot of interesting work in the area, but because AI is something we all talk about, something that everyone thinks is going to change everything and make the world a better place. And I think a couple of things from the presentations. First of all, they were international, and it was quite clear that there is a way forward if you think things through carefully, in which we can use AI to look at areas like differential diagnosis, prognosis, personalized medicine, and prediction. And I think what's also really valuable is that AI allows us to access real world data. And that's data which we haven't been able to touch up until now because it's too messy, it's too noisy. And Armin's work, and then the presentation by Tim Spellman in particular, where he looked at a lot of the other studies presented during ECTRIMS, really showed how you could do this. And again, stepping back, because, as I said, this is the first ECTRIMS meeting I haven't been at in 40 years. It's rather ironic that this is the 40th anniversary and I'm stuck in London, but that's life and you have to just go with it. But what I found really valuable was that all the presentations were international, using data sets, say from the UK, from San Francisco, from Denmark, but then American, Israeli, German, UK investigators using them. So it was a truly international effort. And again, I just emphasize, to me, I hadn't noticed this before, but if ECTRIMS is the mechanism by which we bring these powerhouses together to utilize new approaches, new mechanisms, and to work on new treatments, then it's an incredibly effective role for the meeting. And maybe it's been becoming more and more obvious over the years. So that was a really, really good session. I suppose that, looking back on the meeting as a whole, I mean, obviously there was huge excitement and anticipation around the diagnostic criteria presentation. And that was a great presentation, very comprehensive, and I think demonstrated just how much the criteria are changing and how much they're bringing in new techniques, but doing so in a very intelligent way, which makes it possible for the neurologists to get their head around and to use earlier diagnosis. Also really looking at potentially shining the light on mechanisms, and that's really important. And so Xavier Montalban did a great job, and Marcello and all the others speaking on those topics. I think I also found the presentation on phenotypes, or well, I don't like to use the word phenotype. I think disease course is much more appropriate, but on how we describe MS and how those groupings are changing and how we make them more relevant to the underlying pathology. That was, Fred Luplin's presentation was very thought-provoking. This is still a very much a journey, very much in progress, very challenging. But all of these things, the criteria, the phenotype, some of the work this morning, are all suggesting that we need to bring these together, that we're learning more about underlying mechanisms, and we can translate that into how we think about MS and how we can describe it. And that in turn will help to unravel mechanisms. So it seemed to me, and again, maybe it's because I'm not stuck in the middle of it and rushing from room to room, it seemed to me to be really coherent and quite really encouraging.
Yeah, and it's obviously, as you say, it's disappointing that you can't be here in person for this conference, but I think it talks to where we are at now with ECTRIMS, with the fact that you're still able to engage so readily and easily with the meeting through the live streams that are available that not that long ago wouldn't have been a possibility.
No.
As sort of a final point, you touched on the fact that, this is the 40th anniversary of ECTRIMS. Would love for you to finish off our last Congress podcast of this conference by reflecting a little bit on the fact that we've reached 40 years of ECTRIMS.
Well, 40 is quite old. Of course, you can get older, but 40 is a good time. And if I think back to the early meetings with 50 to 100 people sitting in a room and basically expressing their views, some sensible and some not quite so sensible, to evolving to a meeting which involves many thousands. And I think there was a stage where it was it was big in number, but perhaps the quality wasn't quite there. But what that has evolved further into a meeting now, which I think has got great quality and great coherence. So it's very focused. It's focused on the big issues, if you like. In the end, the ultimate issue around identifying new treatments that reduce the burden of MS on those with it and all those affected by it. And we're seeing that happening year on year. But I think we're also seeing much a unanimity in how we might diagnose, in how we might describe, and in the the mechanisms we need to target. So it's really matured. It's a much more sophisticated meeting. Of course, the planning committee do a great job in bringing all of this together. But I just get a sense that it's an organization now that knows where it's going, that has a real sense of purpose and a real clarity about the future, which is fantastic progress for a mere 40 years.
Well, I think that is the perfect note to finish on. Look, I want to thank you so much, Alan, for joining us, for taking time to join us remotely for the podcast today and sharing all of your wonderful insights into not only today's sessions, but the conference as a whole.
Many thanks, Brett, and thank you very much for inviting me. It's been a real pleasure. Also, thanks everyone for listening. Once again, I'm Brett Drummond, host of this podcast episode and co-founder of MS Translate. The ECTRIMS podcast is produced and hosted in collaboration with two key partners: MS Translate, an independent resource centre that aims to simplify the complex wealth of information about MS for the greater MS community, and the MS Journal, a peer-reviewed international journal that focuses on MS, neuromyelitis optica, and other related autoimmune diseases of the central nervous system. The 2024-25 ECTRIMS podcast series is supported by educational grant providers, including Alexion AstraZeneca Rare Disease. These grant providers have no input in the podcast content. You can subscribe to the ECTRIMS podcast on your favourite podcast channels, including Apple and Spotify. Visit the official ECTRIMS 2024 website to learn more about the ECTRIMS Congress and join the conversations on X, LinkedIn, Facebook, and YouTube.